Thank you. Good afternoon, everyone. It's my pleasure to be here to talk about functional mitral regurgitation and percutaneous treatment. Oh. Yeah, I did it. Okay, so I have no conflict of interest. So why do we need percutaneous treatment for mitral regurgitation? As you can see here, when we look at a whole population of patients with isolated mitral regurgitation, in patients with severe mitral regurgitation, you can see that half of the patients do not undergo intervention because of the high risk, because they decline for surgery. And when we look deeper into these numbers, we can see that most of those patients are suffering from secondary mitral regurgitation. So 2/3 of the patients with secondary mitral regurgitation, significant one, symptomatic, are declined for surgery and do not undergo treatment. Why do these patients do not have surgery? Mostly because so far we don't have any strong data supporting the surgery in secondary mitral regurgitation. We have this randomized study that was performed a few years ago, and in patients who were scheduled for CABG and who had grade 3 mitral regurgitation, they were randomized to undergo mitral valve repair or just CABG during the surgery. And when we look at the results in this patient, we see that there's absolutely no benefit regarding survival, absolutely no benefit regarding the events. And when we look at the symptoms, which may have improved, we're quite disappointed also because there's absolutely no improvement in the symptom of those patients who had grade 3 MR. So one may argue that it's because those MR were not significant enough, and we have a registry which is much more old, and we compared patients with grade 3 or 4 MR between optimal medical therapy and mitral valve repair. And you can see with a very long follow-up that regarding survival, there's absolutely no difference between patients who undergo mitral surgery and patients who just have optimal medical therapy. So all these patients are at high risk. There's no clear benefit of surgery in those patients, so most of them are often declined for surgery, and that's the reason why we need percutaneous treatment. For percutaneous treatment, the options we have are now multiple. We have the repair with the transcatheter edge-to-edge repair, which is the most studied technique so far. We have randomized controlled trial for secondary mitral regurgitation. We have other techniques such as annuloplasty and chordal implantation that I won't talk about today. And now, for a few years, we now have the mitral replacement, percutaneous. We have less data regarding those techniques. We know that we have very good functional results, a lot of anatomical exclusion before we do the implantation, and it's developing technique, so we don't have a lot of data. What do we have regarding secondary mitral regurgitation and MitraClip? The first study that was published, you probably have seen this study before, is the MITRA-FR study, which was performed in France and compared MitraClip to medical therapy alone in patients with secondary mitral regurgitation. And the results of this study was very disappointing for all the interventional cardiologists because we showed that MitraClip in those patients did not do any better than optical medical therapy. There was absolutely no difference at 1 year. There's absolutely no difference at 2 years also. And we had a kind of big disappointment. But a few years later, we had a study performed by the Americans, the COAPT study, who had really, really different results. We had a dramatic improvement in survival in this patient with heart failure and secondary mitral regurgitation, a decrease in mortality that we had not observed before, even with the best medical treatment. So we asked, why are the Americans so better than the French? And the reason is mostly related to the population that were included in those two different studies. At the time, it's been said before, the guidelines for mitral regurgitation evaluation in Europe and in the US were not the same. And as a consequence, the patients that were enrolled in the COAPT study had much more severe mitral regurgitation. More than 40% of the patients had mitral regurgitation with an orifice above 40 millimeters square, while in the French study, only 16% of the patient has really severe mitral regurgitation. The other difference is that in the French study, patients had very impaired left ventricle compared to the US study. And as a summarize, in the French study, patients were mostly suffering from a disease of the LV with mitral regurgitation that was just the consequence of this dilation, while in the US study, the mitral regurgitation was really the main problem of this patient. And people came up with the concept, which has been described before, of disproportionate mitral regurgitation, meaning that the mitral regurgitation is much bigger than what would be expected with such a LV dilation. And when you look at, when you look at the ratio between the mitral regurgitation and the LV diastolic volume, you can see that the patient from the COAPT study have a huge mitral regurgitation and the LV which is not so dilated, while the patient from the French study has a very dilated left ventricle and a small mitral regurgitation. So now we know that we have a lot of ratio that we can use between this mitral regurgitation and the severity of the LV dilation, but we know that we can improve prognosis of patients with mitral clip in patients who have very severe mitral regurgitation but not so impaired left ventricle. We have now 5 years results of this COAPT study, and you can see that the benefit is sustained over time. We still have a very good improvement of the hospitalization and of mortality in this patient. And what is very interesting to show is that we have very few clip-related events. In all those patients that underwent mitral clip, over 4 years, we have only 4 clip-related events, clip detachment or endocarditis or any adverse events related to the clip, which is very reassuring for the longevity of the technique. We now have more data with a lot of patients with a post-approval study of the mitral clip in the US, in which all patients who underwent mitral clip for secondary mitral regurgitation were included. In this patient, you could see that you had COAPT-like patient, mitral FL-like patient, and we have very good results, although the patients were more sick than in the previous study. We still have a higher rate of events in the mitral FL-like patient as compared to the COAPT-like patient, but with the improvement of the technique, the improvement of the operator, we now have very few events in this heart failure patient when we use mitral clip, and maybe with the improvement of the device of the operator, we may have even better results. What do we have for replacement in secondary mitral regurgitation? We only have registries because there's so far a lot of dispositives with 10 or 100 of patients implanted in the world. So what we have now is kind of bag in which they put all the percutaneous valves, and it's been compared in to optimal medical therapy, 2 different cohorts from 2 different registries. They do propensity score matching, and we have 100 patients in each group. What we can see is that regarding mortality, we don't have a difference with mitral replacement, but it must be highlighted that the patients who undergo mitral valve replacement are so far only compassionate patients, so they're very sick. We don't have anything to offer to them. Usually they're declined for mitral clip. And this is the first patient that were implanted with all these valves, so the technique is difficult, people are learning, so that may be the worst patient that we'll ever have with transcatheter mitral valve replacement. But when we look at the heart failure hospitalization, we can see that we have a strong decrease in the hospitalization with the mitral valve replacement, which may pave the way for future trials. We've also compared replacement and repair. So patient from a large registry of TMVR was compared to patients with mitral clip. And we have now a lot of patients, almost 200 in the replacement group and 400 in the mitral clip group. And what we see is that consistently with the replacement device for the tricuspid, for the mitral valve, replacement always do better on the regurgitation. It always treats the regurgitation. You can see here that in the replacement group, all patients are 0 or grade 1 MR, which is not the case in the TER group. And when we look at the outcome, there's no significant difference, but it seems on this first data that the first replacement do a bit worse, do less good than the TER, mostly because those patients with TER are highly selected, we know them, we know the technique, while in the replacement group we have 10 patients with my valve, 10 patients with this one, 50 patients with Intrepid, 50 patients with Standine. So all those patients are on the learning curves of the operators, so they may not reflect what we will have with replacement. As a conclusion, we have so far very few data supporting surgery for functional MR. TER improves outcome in selected patients. These patients have to have a disease which is mostly a mitral regurgitation, but not LV disease with very dilated and dysfunctional LV. TMV replacement, we are very early experience. There's a very good MR reduction compared to repair. There's a lot of anatomical exclusion. I have not time to discuss about this, but 70% of patients screened for percutaneous repair are declined because of the anatomy. And we have so far inconclusive data regarding outcome. Thank you very much.